Okay, so welcome back. So let's move on now to our next topic, which will be depression and anxiety. We'll talk about them separately from one another. So depression has a lot of different aspects of it that are part of for example, a clinical diagnosis. So one is loss of interest in pleasurable activities. So when people have depression onset, a lot of times they will no longer really take joy in activities that they used to take joy in. Maybe they liked going to the movies, maybe they like playing soccer, maybe they like, I don't know, doing any number of things, but they'll kind of become somewhat apathetic towards it. There can be severe changes in appetite, and it actually can go either way. Sometimes people in the midst of depression will have a serious increase in appetite, or maybe a pretty serious decrease in appetite. Sometimes it's even a change of appetite. For example, they might, usually they're eat very healthily, and perhaps they'll actually change, maybe eat a little bit more junk food. There can be sleep disorders. Again, it can go either way, either too much or too little. Sometimes people with depression will report that they sleep too much to kind of almost as an escape because they are trying to avoid, their depressive thoughts, or sometimes they'll even say they wish they could sleep, but for whatever reason they're unable to. A loss of energy or motivation, somewhat related to a loss of interest in pleasure activities. And then also sometimes difficulty thinking, concentrating, or making decisions because their mind is so preoccupied, oftentimes by the somewhat intrusive depressive thoughts. Okay, a couple of sort of facts about what's going on in terms of depression in society more generally. One is actually that depression rates are on the rise over time. And so this only goes to 2015, but I can assure you that the rates are continuing to increase. Now, why is depression increasing? This is a question somewhat related to what we talked about when we talked about autism, where one possibility is that it's not that actually the underlying rates are really changing that much. It's just that the diagnosis rate is changing quite a bit because we're now recognizing what it is and diagnosing it as such. Alternatively, some people have argued, in fact, that perhaps with modern society and the differences of our cultures as they have changed and naturally adapt over time, perhaps really there is more depression over time because of these somewhat external cues. Interestingly enough, though, while we talked about with autism how there is an increased prevalence amongst autism amongst males, the opposite is true when it comes to depression, where major depression disorder is pretty much across the board, and you can see in all these different countries, it is a higher rate. It is seen that there's a higher rate amongst females than males, that women are thought to be more susceptible to depression. Now, again, why is that? There's some conflicting ideas. One idea is that perhaps there is something about the differences in the underlying biology between males and females that predisposes females then to males. Another is that this is a social phenomenon, and that in certain cultures, women are more willing or able to talk about their depression, whereas men might be experiencing it at a similar rate, but don't feel as if they're able to, or it would be as accepted and so forth. Somewhat similar to how it was with schizophrenia, though, of course, there is a heritability aspect of depression. So here's actually showing you the kind of the correlations across a bunch of different dimensions: height, weight, intelligence, schizophrenia, and you can see that it's higher for identical twins than fraternal twins. This is also true in terms of things like depression and happiness. So if you were to give me two twins and you were to tell me like one of these twins identical twins had severe depression, I would think like, oh, there's a pretty good likelihood that the other twin does as well. Similarly, if you're to tell me one of these twins, great disposition, very happy, and so on and so forth, I would think there's a good chance the other twin would as well. So this sort of heritability difference between identical and fraternal twins shows that there is some sort of heritability genetic aspect to it. But let's focus primarily on depression in the brain. And one of the major telltale signatures, maybe like the first signature that was really noticed, is that depression changes brain metabolism and blood flow, specifically in the frontal cortex. So if you look at metabolic activity across the brain, this is the front of the brain here, this is the cerebellum, the occipital lobe back there. If you look at individuals with who do not have depression versus people with chronic depression, you can see that there's just an overall decrease in activation in the frontal lobe. That's what it's meant by changes in metabolism and blood flow in the frontal cortex. So this is from one study, but of course it's not necessarily only just in that particular brain area, because here is another study that, sure enough, while you can see some changes in the frontal lobe for sure, sometimes you also see changes other places in the brain. And to really highlight how this is something that can be found at a group level, but can't really be used as a diagnostic marker. Here are actually two individuals with the same exact symptoms, and now they're color coding metabolism and blood flow in terms of red. And you can just see like these brains may look very different from one another, but they actually have the same external symptomatology. So I really want to stress that it is not the case that people with any individual you meet with depression, you could talk about their frontal lobe or their metabolic activity this way, nor is it the case that clinicians could use this to diagnose individuals. But it's still at least been shown again and again and again that if you get a large sample of people without depression and a large sample of people who are with it, who have depression, you will see this overall difference between the two groups. Another way that I can really hopefully drive home this idea that these differences should be, I don't want to say taken with a grain of salt because they're definitely very reliable, but I guess, not taken with a grain of salt, but not over-interpreted and overextended is the fact that this difference in the frontal lobe might remind some of you about the difference between typical individuals and psychopathic individuals. And so you might be thinking, oh, does this imply that people with chronic depression have psychopathic tendencies? No, because the frontal lobe is a very complex circuit. This is an extremely crude measure. Sure, there might be differences in metabolic activity. They may manifest in different ways. They may affect different parts of the frontal lobe in different ways. They may affect connections in different ways. But like I said earlier, when we were talking about schizophrenia, when doctors first started trying to understand the differences between the depressed and the healthy brain, one of the first things that they noticed was, hey, on average, we're noticing this difference. And now they're really working to kind of take that next step and to understand, well, what are these differences in particular? How is it manifested in the brain and so forth? And so when talking about the different mechanisms of depression, in addition to talking about things at a sort of macro scale of something like the frontal lobe, we also talked early on about depression and serotonin. And so just to review this really quickly, the idea is that in the typical brain, there is a certain amount of serotonin that is getting processed by the brain and is getting processed in between different neurotransmitters, whereas in the depressed brain, there is not as much serotonin, a particular neurotransmitter. And so what a lot of drugs that are doing, which are called SSRIs, selective serotonin reuptake inhibitors, is they try to block the reuptake of serotonin so that the serotonin that does get out there stays out there in the synapse longer. It has a greater probability of getting processed by the postsynaptic cell. Again, I think this is the image that we saw earlier where the SSRIs literally will block the serotonin reuptake channel so that it will stay in the synapse even longer. But some treatments, even though this might be, this is kind of like depression treatment 101, new treatments are being developed actually in light of the fact that there are those sorts of differences that we were talking about a second ago related to metabolism and activity in the frontal lobe. Wait, I'm going to pause the video for 1 second, guys. Sorry about this because I can tell that I'm going to sneeze. Hold on. Okay. Oh boy. Sorry about that. Some treatment options are now trying to work based at this level by thinking like, hey, maybe there could be a way that we could stimulate the frontal lobe, and maybe by increasing the activation in the frontal lobe, we can help relieve some of the symptoms of depression. And so some treatments that are being developed actually use TMS, except it's a special kind of TMS that is not designed to turn off parts of the brain, which is what we've mostly talked about using it for, but actually to turn on parts of the brain. And so the idea is people could come in, have TMS applied to the frontal lobe, maybe that will help them. And actually for some people for whom the depression is, very, very bad, and a lot of different sort of treatments have not worked, and they're really kind of running out of options, there will actually be people who will get deep brain stimulation. And so the way this works is you will target certain parts of the frontal lobe. In this case, for example, for a region like depression, it could be a region that's called area 25 in the frontal lobe. And what you do is you have basically a neurostimulator. It's like a power source, the same type of power source that you would have for like a pacemaker. And it's literally under your skin right about here in your pec or under your collarbone. And it is like the battery and then there'll be a wire that'll run through your neck and then drill into your head, and it will kind of regularly be stimulating your frontal lobe to hopefully make it more activated. And at night, literally, I don't totally get how this works, but it's some sort of like not wireless, but like you put a charger up to the battery, like it doesn't have to it's like through the skin, it can get charged up at night. And so then it will work for the rest of the day, the following day, and so forth. And just to give you a sense of what this looks like in actuality, this is an X-ray where we're looking at someone head on, and you can see these bilateral chronic deep electrodes that are going into the frontal lobe to do this chronic deep brain stimulation. I would feel remiss though if I didn't measure what another very simple but effective treatment of depression is. Arguably, I've seen many people claim that it is the most effective treatment of depression. It's not a particular type of medicine that targets a neurotransmitter. It's not deep brain stimulation or TMS. It's actually just exercise. And so there have been so many studies that are like this one here, where you look at people's depression scores as a function of time. And what you find is that if you get a group of people who, start off with fairly high depression rates early on, the group that is forced to do regular aerobic exercise, their depression rates will go down significantly, and actually significantly more even than individuals who are in a placebo medicine group who are told, like, this is a medicine that will help you with your depression. So it actually turns out that when you hear clinicians, therapists, people talk about, for mental health, getting up, being active is helpful, there's a lot of science to really back that up, that it actually seems in a lot of in a lot of clinical studies that have been peer reviewed and so forth, exercise has really been shown to be extremely effective. And like I said, some people argue the most effective. Okay, so now let's move on to anxiety, which often co-occurs with depression, but they are certainly different from one another. And unfortunately, anxiety is particularly prevalent in Western cultures, especially the United States, where anywhere between 5 to 20% of the people in the country struggling with anxiety. Once again, it's more common amongst women than it is amongst men. And like I said, it does often co-occur with depression. So they're referred to as being comorbid. So anxiety has many different domains. There is one domain called generalized anxiety disorder. So it is just chronic excessive fear and worry, but it's not necessarily attached to a specific threat. A lot of times people with generalized anxiety disorder will say, like, oh, I'm anxious about this now, but as soon as this goes away, I'm sure it could, go on to something else. They kind of describe it as like, I always can kind of find something to be anxious about. So that's generalized anxiety disorder. There can be panic disorders, which can be these recurrent episodes of these intense anxiety type of events. It's almost like having constant panic attacks for no real reason, which can be very serious. Sometimes people who have serious anxiety attacks will actually think that they're having a heart attack and will get rushed to the emergency room because they think that they're having a heart attack. And then actually another branch of anxiety disorders that I think people sometimes don't think of initially is phobias. That phobias are different sorts of anxiety disorders in just certain domains. So some people can be agoraphobic, which is the fear or avoidance of embarrassing or inescapable situations, specifically in large public spaces. A lot of times they talk about having a fear of having a panic attack, and they're nervous about what will happen if they go outside, and so they will refuse to leave the house. There can be social phobias. A lot of people will talk about having social anxiety. Sorry, this cuts off here. Public speaking is the term over there. Then there are, of course, many sort of specific phobias. What's it called? I wrote down a few. Claustrophobia, fear of small spaces, a lot of people are aware of. Arachnophobia, fear of spiders. Acrophobia, fear of heights. What's this called? Coulrophobia, which is a fear of clowns. So this is really referred to as a specific type of phobia. And it turns out that actually when you're talking about anxiety, there are many more than just these. So for example, two other ones are obsessive compulsive disorders and post-traumatic stress disorders. And we're actually going to go talk in a second about post-traumatic stress disorders in particular. But one thing I do want to talk about is the relationship between anxiety disorders and these two different aspects of your nervous system, which are called the sympathetic system and the parasympathetic system. The sympathetic system is the part of the brain and the nervous system that prepares the body for action. The parasympathetic system is the part that returns the body down to a resting state. And so what's going on is with the sympathetic system, it preps the body for action. It makes your eyes bigger so you can see more. It releases adrenaline so you're ready to act. It opens up the lungs. It dilates the muscles so you're ready to act. The parasympathetic, it will then slow the heartbeat, constrict the pupils and so forth. And for a lot of individuals who have anxiety disorders, you can see an overactive sympathetic system, that their respiration will increase, their eyes will dilate, their heart will be beating really fast, as if it's responding to an external cue that is stressing them out, but it might not actually even be there. And so sometimes an overactive sympathetic system can, by virtue of the fact that it is triggering these physiological responses, can cause people to having anxiety feelings. Now, before we dive in deep into the brain of anxiety, I do really want to emphasize that while we're going to talk about one particular part of the brain in a second, specifically the amygdala, I do want to make sure I give a shout out to the fact that many different parts of the brain have been implicated in anxiety, that there is a greater gray matter and hyperactivity in several parts of the brain, the amygdala, ACC, which we talked about a few weeks ago, post-central gyrus. But then there's also been shown that there is decrease in gray matter and hypoactivation. Hypoactivation means less active. And then also gray matter volume and hyperactivation also as well in the VLPFC, the ventrolateral prefrontal cortex. So there are a whole lot of parts of the brain that have been implicated for sure in anxiety. How they all fit together is not super well understood, but so I thought for the purposes of this course, we could relate it back to what we talked a little bit ago about emotions in the brain, specifically talking about the amygdala. And as I hope will not come as a super shock, you can see that if you show participants on the left, what I have is participants with GAD, means generalized anxiety disorder, and control participants over here, aversive and neutral stimuli to the left and right amygdala. And what you actually find is that in both cases, even if the stimulus is aversive or neutral, you can find there is this overactivity in this particular brain region in the amygdala for people with anxiety disorders, relative to individuals who do not have any sort of anxiety issues. And so this makes some sense that people who are anxious are going to have heightened, fear responses, heightened aggressive, heightened anxiety responses triggered by something like an overactive amygdala. And actually, this idea of an overactive amygdala in these anxiety disorders has been especially noticed in PTSD. And so PTSD, for those of you who might not be super familiar, of course, stands for post-traumatic stress disorder. And the thing about post-traumatic stress disorder is that the way to think about it is these sort of vivid and intrusive recollections of a traumatic situation. A lot of times people with PTSD will report that they're not only thinking about the traumatic situation, they're kind of actually actively reliving it in a sense in the moment. And so what will happen is, in terms of their behavior, there will be serious avoidance of certain situations that are related to the experience. And it can easily be triggered by something that is related to that experience. The sort of canonical anecdote people talk about is war veterans who will sometimes have a traumatic episode evoked. They'll have an episode because they'll hear a firecracker or they'll hear a car backfire, and that will remind them of the sounds of something that was related to the traumatic situation. But it turns out that individuals with post-traumatic stress disorder, when they're in the midst of having an episode, will have, as you can expect, an overactive amygdala. So in a really creative way that some people, actually multiple people in the different discussion sections talked about, is could you use something like memory reconsolidation as a tool to treat post-traumatic stress? And that is exactly what some people have done. So just as a recollection, the way that this reconsolidation theory is thought to go is that when something is in an active state in short-term memory, your mind is currently processing it. And then every time it gets reactivated from this purple thing, it will have to be reconsolidated. Okay, so it's active state, reconsolidated, active state, reconsolidated. So what these clinicians had this idea is like, okay, well, wait a minute. If every time you have to relive the traumatic episode, it's in effect in an active state, maybe we could actually use that as an opportunity to treat the individual during the reconsolidation process to get them to reconsolidate a memory that is not as anxiety inducing. And so it turns out that there is a drug called propranolol, which you can just a pill you can take, that selectively targets the amygdala and suppresses activity in the amygdala in particular. And if you remember patient SM had Urbach-Vita disease, which would target her amygdala as well. That's because the amygdala has a unique genetic signature that something like Urbach-Victa disease could target. And in this case, to the benefit of physicians, propranolol can kind of key in on that genetic signature as well, and it will selectively suppress the amygdala. So the question that these physicians have asked is, well, will quote unquote numbing the amygdala with propranolol after the traumatic memory was recalled cause it to be reconsolidated without the extremes emotions associated with it? So the idea is you force an individual to have the traumatic recollection, you bring the memory into the active state, and then when it's in the active state, you give them the propranolol so that when they reconsolidate it, what they're reconsolidating is a suppressed type of experience, because when you suppress the amygdala, they won't be having as much anxiety, they won't be having as many, their heart rate and respiration won't be as fast. And so maybe then the next time it gets brought up, what gets brought up will have been reconsolidated with a sort of lower affect. So here I'm going to show you two biological measures, heart rate in terms of beat per minute, and physiological response, which is skin conductance. Just to remind you, skin conductance and physiological response in this case, if you remember the Capgras delusion, we talked about how you could measure someone's skin conductance when they're looking at individuals that they know versus individuals that they don't. It's the same sort of physiological response. So what we're going to look is a group of control individuals with PTSD who do not get the propranolol treatment, and then a group that do get the propranolol treatment. And what we can see is that there is a significant effect between the group who are in the control and the group who got the propranolol. Basically, those who got the propranolol treatment, these two responses in heart rate and skin conductance both decreased with subsequent recollection of the experience. This dotted line, by the way, is thought to be the sort of threshold that one has to cross to be diagnosed as having post-traumatic stress. So in this case, the control is right at the threshold here. This group of controls is above it, whereas the two propranolol groups are both below it. But like I said, are there other regions that are involved in the anxiety besides the amygdala? Absolutely. We don't really have a whole lot of time to go into many of them, but I do want to talk about at least one more, which is this region of the frontal lobe called the VMPFC, which is the ventromedial prefrontal cortex. And that's what you can see here and highlighted in red. Now, this that I'm going to tell you about is actually a study. The classic one has been done in rats, but people have now been thinking about how it relates to the VMPFC in humans. So in this is a conditioning type of study where basically you get a rat to associate something like a tone with a shock. And so the rat eventually will learn, every time I hear the tone, I'm about to get shocked. And when they know that the shock is coming, they will experience freezing behavior where they'll kind of hold in place. That's what rats do when they're scared, as it were. And you have two groups, the group in green and red who is the sham group. In effect, they don't get the surgery. And then the other group is the VMPFC lesion group, where basically you surgically lesion the VMPFC. And it turns out that when it comes to learning about how to associate an aversive stimulus with a shock, or a neutral stimulus with an aversive response, which there's the shock in this case, both groups learn it pretty quickly. In day one, it doesn't take that many trials for both groups of rats to understand that the tone means a shock is coming. And then both groups experience, relatively natural rates of extinction, whereas, you start playing the tone and then you stop shocking them, at first they're like, oh, I guess, okay, the tone, we don't have to be as scared of it. I do want to point out there is a little bit of a difference where you can see that these purple diamonds are a little bit higher than the green circles. So it's a little bit of an effect where you can kind of see that the anxiety associated with the tone lasts a little bit longer in the VMPFC lesion group than it does in the sham group. However, where you can really see an effect is in day two, okay? Because there's this thing that is referred to in the conditioning literature called spontaneous recovery, where basically even after the rat has learned, oh, the tone isn't scary, on the second day, if you play the tone again, they'll still kind of retain that, they'll kind of spontaneously recover that association they had between the tone and the shock. So they're like, yeah, I learned it was bad, and then I learned it might not be that bad, but you know what, it's the next day, I don't really know what's gonna go on, not 100% sure. So you'll still see some freezing behavior. But what they found is actually the freezing behavior was much higher for the animals that had their VMPFC lesion than for the animals that didn't. And so this idea is that they don't retain this extinction learning. And so basically they don't let go of the past fear. And so what scientists then kind of theorize then is that, oh, maybe what's going on is that individuals, humans in this case, who have struggled with generalized anxiety, they might have lower activation of the ventral medial prefrontal cortex. And specifically, they found it when they first looked into individuals with PTSD, because it was this idea that they basically couldn't let go of these sort of frightening and aversive stimuli. Oh, sorry, I forgot about the animations. And so the idea is they use these sorts of results from an animal model to look at the VMPFC in individuals, not just with PTSD actually, but with generalized anxiety disorder. And because the idea is that since the VMPFC isn't functioning as well as it potentially could be, people are kind of holding on to frightening stimuli or frightening experiences a little bit longer than they would under more typical circumstances. But like I said, there's a lot of other parts of the brain that are definitely involved in anxiety. So this is really just to hopefully serve as an introduction to get a sense of how people understand things like anxiety and also relatedly depression from a cognitive neuroscience perspective. Okay, so let's take a break then, and we will actually change pace a little bit, and we will move to talking about closed head injuries, concussions, and CTE, which stands for chronic traumatic encephalopathy. But that's what we'll do in part 3. So I will see you all there. How do I end this meeting? There we go.